Okay, let's get into this one-page talk about kind of big ticket cardiac physiology stuff. Okay, the first thing that we need to talk about when we're thinking about cardiac physiology is the terms that we're using. Okay, and the basic equations that you need to start understanding the physiology of the heart. Now, the first thing that we're going to talk about is end systolic volume. So, what's end systolic volume? It's all in the name. It's the volume at the end of systole. So after the heart contracts, how much volume is left in that left ventricle, right? So that is volume in left ventricle at end systole, okay? The next term we're going to talk about is end diastolic volume. Now, I bet you could figure out what end diastolic volume is. That's right, it's the volume at the end of diastole. So after the heart has fully relaxed, what's the volume of blood in that left ventricle, right? So volume in left ventricle at end of diastole. All right, why is it important to know those things? Well, those volumes really are kind of the bedrock of how we determine all of our other values, right? So the next thing that we need to talk about is stroke volume. So what's stroke volume? Stroke volume is the amount of blood ejected out of the left ventricle at each cardiac cycle, right? So how would you determine the volume? Oh, well, that's pretty easy. You would take the end diastolic volume, and then you'd minus the end systolic volume, right? And that would give you how much blood was ejected. Moving on from that, we can then use the stroke volume to help us figure out our ejection fraction. Now, the ejection fraction is basically the percentage of blood that is ejected during each cardiac cycle. You guys have probably heard this before, especially when talking about heart failure. But clinically, it's the best kind of indicator that we have of cardiac output, right? And you get ejection fraction from getting a transthoracic echo or a transesophageal echo, but you get it from an echocardiogram, right? So ejection fraction, percentage of blood ejected during systole, right? So if we want a percentage, we're going to have to divide by some stuff, right? So we have our end diastolic volume minus our end systolic volume divided by our end diastolic volume, right? So that's going to give us our percentage. So that's also the same as saying, let's put it in parentheses, that's also saying it's our stroke volume divided by our end diastolic volume, and then you times 100%. And that's going to give you your ejection fraction. Very clinically useful number to know. Now you have your actual cardiac output, right? So what is the cardiac output, right? Cardiac output is going to be in liters per minute, right? So how much blood volume is your heart pumping every minute? So if we know that each cardiac cycle has a stroke volume, that's a volume that we need, right? So we have our stroke volume, and that if that's for one beat, if we times it by our heart rate, which is per minute, we will get our cardiac output, right? Now, those are kind of the big ones for, the chambers of the heart. Now, what about our kind of vascular stuff, right? Well, the first one is our blood pressure. So what makes up our blood pressure? Well, we have two values. We have our systolic blood pressure, and we have our diastolic blood pressure, right? Our systolic blood pressure is determined by the contraction and the stroke volume of the left ventricle, right? It's the pressure that's the maximum amount of pressure exerted on the arterial wall, right? And then that is determined by stroke volume, right? So the higher stroke volume, higher systolic pressures. Lower stroke volume, lower systolic pressures. Now our diastolic pressures are the pressure exerted on when the heart is relaxed, right? So it's kind of like your baseline pressure. So our diastolic blood pressure is really determined by our systemic vascular resistance, right? So the kind of the resistance to that forward blood flow that our vasculature is exerting at baseline. Now, once you have your blood pressure, you can calculate something called a pulse pressure. Now, a pulse pressure is just the difference between the systolic blood pressure and the diastolic blood pressure. So it's systolic blood pressure minus diastolic blood pressure. And this is proportional to SVR, or to stroke volume, excuse me. Okay? Next, we're going to talk about the MAP, or the mean arterial pressure. Right? Everybody talks about blood pressure, systolic over diastolic, but when you're titrating someone's blood pressure, or you're using vasoactive agents, you're really worried about the MAP when you're in kind of the acute care setting, right, in the hospital setting. And it's the mean arterial pressure. So it's much more indicative of the perfusion pressure of the organs rather than just the systolic and diastolic blood pressures alone, because it's kind of like the average of the two, right? So to calculate the MAP, there's two different ways. You can do 2/3 diastolic blood pressure plus 1/3 systolic blood pressure. Or you can think of it as cardiac output times the systemic vascular resistance. Systemic vascular resistance is also sometimes called total peripheral resistance. So you may see abbreviated SVR, it may be TPR, but it's the systemic resistance exerted by the vasculature at baseline, okay? So what is SVR, right? So we have our systemic vascular resistance. Now, as I said, SVR is the sum of the peripheral resistance experienced by the left ventricle, right? So what is that pumping against? And if we think about it in that way, we can think about it kind of as a physics equation, right? So we can think of SVR as our resistance, right? Our resistance to forward flow. Now, the resistance of forward flow is the delta P over Q. Now, delta P is the driving pressure, right? And the Q is the flow. So the driving pressure is the difference between the systemic vascular resistance and the force applied by the left ventricle, right? So you have to overcome that systemic vascular resistance to then be able to perfuse, right? Because if you're not overcoming that systemic vascular resistance, that blood isn't going to be able to go anywhere. So that's why when your systemic vascular resistance is high, your heart has to work harder to overcome it. And that leads to, negative consequences down the road from uncontrolled hypertension, like, cardiac hypertrophy, and, even can lead to things like heart failure. So we have our resistance. Now, the formula for resistance, if you can remember this, is actually very useful in thinking about systemic vascular resistance and kind of ways to help and or hinder it. So the actual formula is 8N, which is a constant, times the viscosity of the blood times the length of the vessel divided by pi times the radius to the fourth, right? So what does that tell us, right? Well, it tells us a couple things. First, it tells us that viscosity and length are directly proportional to resistance, right? So if you increase viscosity, you're going to proportionally increase resistance. If you increase length of the vessel, you're proportionally increasing the resistance. But what's really important here is this r to the fourth, right? So it's exponential, right? So increasing the radius of a artery or a vessel exponentially decreases the resistance because these are inversely related. So if you increase the radius, right, the pipe goes from here to here, obviously you're going to decrease your resistance. So being able to kind of think about systemic vascular resistance in those terms is very helpful. Now, we have a different thing to talk about with resistance, and that's resistance in series versus resistance in parallel, right? So resistance in series is like you have R1, and then you have a different resistance R2, and you have a different resistance R3, okay? And to calculate the total resistance of these is really easy. It's just R1 plus R2 plus R3 equals whatever, R total, right? So they're in series, boom, 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 boom. Okay, that's great. But what if I have something like this? I have a pipe that kind of comes off like this, boom. And then it comes back together, right? What's this, right? We have a resistance here, R1, we have resistance here, R2, we have resistance here, R3. What are those resistances? How do we figure that out, right? They're not in series, we can't just add them together, right? Well, that's when we do R total equals 1 over R1 plus 1 over R2 plus 1 over R3, right? And that equals R total. Now, when you have things in series, as you add the resistance, the resistance increases, right? But what about this one? As you add something in parallel, you're actually going to be decreasing that resistance, right? Because this bottom number is going to be getting larger, right? So you're going to have less resistance. Now that's important because, the capillary system is set up in parallel, right? It's not set up in series. So that's why when they talk about where does the most resistance from the vascular system come from, it's not the capillaries, right? You would think it would be because they're the smallest, right? And we talked about radius and all that stuff, but really it's the arterioles. So arterioles equals most resistance in the system, and then the highest cross-sectional area in parallel is actually the capillaries. So the capillaries equals the lowest resistance, right? And that would make sense, right? Because we want a low resistance in the capillary bed so the blood slows down and it has time to diffuse out the oxygen into the tissues that's required, okay? Now, we have one other thing to talk about, and that is going to be the cardiac pressures, okay? We have our cardiac pressures, okay? First one is going to be our right atrial pressure, and that's about 5 millimeters of mercury, okay? And these are just good to know, especially as you get into rotations, and you're looking at things like right heart caths and, floating a Swan's in or something like that. So just having these in your back pocket is great. So the right atrium is the lowest pressure. The right ventricle, we're going to go about 25 over, about 5 millimeters of mercury again. So right ventricle, a little bit higher. Our pulmonary vasculature is going to have a similar pressure as the right ventricle. And then we're going to have our left ventricle. And then our left ventricle should be similar to our systolic pressure, right? So it's like 120 to 130, and then the diastolic pressure is low, about 5. Right? So these are our kind of pressures of the chambers of the heart. And then we also have something called our coronary perfusion pressure, right? Their coronary perfusion pressure is important because it's the driving pressure that forces blood into the coronary arteries during diastole. Remember, the coronary arteries perfuse during diastole, not during systole, because the heart has to be relaxed for those to be able to have blood flow through them. So basically, the coronary perfusion pressure is the difference in pressure between the aorta and the left ventricle during diastole. Okay? So those are the important equations to know. Next, we're going to do talk about cardiac output. Okay? So cardiac output, as we said, is equal to stroke volume times the heart rate. Okay? Now, we can also deduce cardiac output from something called the Fick principle. Okay? Now, the Fick principle is stating that the cardiac output is equal to the rate of O2 consumption divided by the SaO2 minus the SvO2, right? So SaO2 is the oxygen saturation of the arteries, SvO2 is the oxygen saturation of the venous system, and you can calculate the cardiac output using this Fick principle, making some assumptions. Now, I'm not going to do that right now. You can look more into it if you want. Another important thing to remember is that another way to get a number for cardiac output that's valuable clinically is something called thermodilution, right? And if you have a PA catheter in a central line, you can do something called thermodilution, and it measures basically the time that a heated sample of saline takes to return from circulation and return to normal body temperature. And using that, they can calculate, how much output the heart is having, right? So why does this matter, right? So why do we care about cardiac output, right? So if cardiac output increases, right, that's going to increase the cardiac work, right? And then that increased work is then going to increase the myocardial O2 consumption, right? So basically, the harder the heart has to work, the more work it does, duh. And if there's more work and there's more output, that means the heart needs more O2 to consume, right? And knowing this relationship is important when you're thinking about things like acute coronary syndromes, and things where you're having the need for increased heart rates or increased work of the heart, but your oxygen supply may be low. And what that does is it causes ischemia, and then it can cause damage to the myocardium. So the next thing we need to talk about is the components of cardiac output, right? So what makes up cardiac output? It's not just this, nebulous number that, means, nothing to you, okay? So the first thing that makes up cardiac output is preload. So preload is basically the amount of blood in the left ventricle at the end of, yes, diastole, correct. So what is it? It's the end diastolic volume. Boom, tying it in, baby. So how basically this is asking the question, how much stretch is there in that left ventricle at the end of diastole, right? How outpouched is it, right? How much tension is there, right? Now, the reason that is important is because what happens if you increase preload? Okay, so if I increase my preload, I'm going to increase my end diastolic volume, right? If I increase my end diastolic volume, That means if my heart's functioning normally, I'm going to increase my my stroke volume, right? Because I'm having to pump more blood, I'm increasing the work of my heart, and then I'm also increasing my O2 requirements, right? So this is what happens when you increase preload. Increase preload. All right, so how do you increase preload? Well, you can give volume. You can give, blood. You can give LR. You can give NaCl. You can give fluids. You can give osmotic fluids. You can give blood. You can give, crystalloid fluids. You just want to increase the amount of volume in the system. That's going to increase the amount of blood return to the heart, which is going to increase the end diastolic volume, thus increasing preload. Now, what else can you do? You can have an alpha-1 stimulation via the sympathetic nervous system, right? Now, what does that cause? That causes venoconstriction. So if you constrict the veins, you're going to increase blood return. And if you increase blood return, you're increasing preload. Now, one last way to do it, which you don't do very clinically, but they could ask you about it on a physiology standpoint, is to increase preload, you want to decrease the heart rate, okay? Now, decrease heart rate, why would you say that? Well, because the heart fills during diastole. So you need adequate filling time to increase for the heart to fill, right? So if you have a slower heart rate, you have more time for that heart to fill, you're going to have an increase in preload. That's why when you see things like supraventricular tachycardias or really fast heart rates, your cardiac output falls because you're not having as much time to fill the heart after each beat, and thus you're decreasing your preload, you're decreasing your end diastolic volume, and you're decreasing your stroke volume. So all this stuff is connected. Now, what about decreasing your preload? Well, it's basically just the opposite of this stuff, right? And there's a couple drugs that you can give that, decrease preload. The most common one is probably nitrates, right? And that causes venodilation, which then decreases the preload, right? Because if you're dilating the venous system, unlike, constricting it, like I talked about here, you're decreasing the blood return, right? And if you're decreasing the blood return, you're decreasing the work, and you're going to decrease the O2 requirements, which is why you give it during acute coronary syndrome, right? Because you're trying to save the heart oxygen. So by decreasing preload, you're decreasing the amount of work that the heart needs to do, and you're kind of trying to save some of that tissue that may not be getting oxygen, right? So, talked about preload. Next, we're going to talk about afterload. All right, what is afterload? Afterload is the force resisting left ventricular outflow. So the force that's pushing against the heart, trying to stop it, quote unquote, from pushing that blood out, right? It's like your back pressure, kind of. So what happens if I increase afterload, right? If I increase afterload, I'm going to increase my end systolic volume, right? Because I'm not going to be able to pump as much out across that pressure. I'm going to decrease my stroke volume, right? But I'm increasing my work, and I'm increasing my O2 requirements because I'm having to work harder to get past that higher pressure or that higher force, that higher afterload, right? And that increased work is going to require increased oxygen, right? So, these values are different, the stroke volumes, but the work and the O2 requirements are the same if you increase preload or increase afterload. The difference being that increasing afterload is going to decrease the stroke volume, whereas increasing preload is going to increase the stroke volume. And afterload is going to increase the end systolic volume, whereas preload is going to increase the end diastolic volume. Okay? And an example where, afterload can be increased, are things like aortic stenosis, long-standing hypertension, and something called HOCM, which is a cardiac issue. And we'll have a whole lecture on cardiac stuff about that. So, 2 more things left, okay? The last one is contractility. And, I'm a terrible speller, so judge me if you want. So the contractility is basically, what's the squeeze? What's the squeeze, right? So you're going to have your ejection fraction, right? We talked about the ejection fraction here. So our ejection fraction is its measure clinically. And you get that by getting an echo. Okay? Now, contractility is regulated by a few things, okay? It's regulated a lot, mostly, and the most important one is going to be the sympathetic nervous system, right? So the sympathetic nervous system innervates on beta 1 receptors, right? That beta 1 receptor, when it's stimulated, is going to increase the contractility. It also increases the heart rate, okay? There's more to go into contractility and, calcium levels inside the sarcoplasmic reticulum, and we'll get into that, and we'll talk about it during our cardiac electrophysiology talk, but just big ticket item, beta 1 receptors, sympathetic innervation increases contractility. And it's the most clinically relevant one, right? Because we can mess with this by different pharmacological agents. And then the last one, so we're going to talk about our values. So if I increase contractility, what do you guys think is going to happen to my end systolic volume? That's right, it's going to decrease my end systolic volume, right? So I'm decreasing the amount of blood left after systole, right? So I'm improving the squeeze, right? I'm going to increase my stroke volume then, correct? And then if my contractility increases, my work's going to go up, and so is my O2 consumption. But when we're talking about things like heart failure, right, we want to increase the contractility. So that's why we give, in advanced stage heart failure, things like ionotropic agents, right, to really squeeze that heart, and things like cardiogenic shock, we want the heart to squeeze, right? Because we want to decrease the end systolic volume and thereby increase the stroke volume and then increase, the ejection fraction and what is perfusing the rest of the body. And the last thing that makes up the cardiac output is the heart rate, okay? So if my heart rate increases, what's going to happen to my work? My work increases, right? So does my O2 consumption. And then this is again controlled by beta 1 SNS stimulation, right? So, increasing the heart rate can, increase the work of the heart, increase the oxygen consumption, and then we can modulate that by, targeting the beta 1 receptors with, things like beta blockers and all that kind of stuff. So that is cardiac physiology in a nutshell. Hopefully that was helpful. If not, let me know things I can do to improve. I already know I have crappy handwriting and poor spelling. So yeah, thanks for checking it out and hope you guys enjoyed it. All right, guys, hopefully you got something out of that video. I know it was a little bit longer. Again, I'm very new at making these things, so if you have any suggestions on how to improve my videos, how to improve the quality, if I got anything wrong, please let me know in the comments. And again, if you found it helpful, feel free to share it. I'm really just doing this for me, not trying to get YouTube famous. It's just a good way to force myself to sit down and be able to concisely talk about something or write something out. So hopefully you got something out of it. If not, thanks for giving it a shot. And maybe try another one next time.